thanks to the RCN for letting me share some of our data. So I have no disclosures, not good with students. Our learning objectives. So first, we're going to identify the most common medications used in hemodialysis patients, which I think most of us probably already know, but this will with studies. Identify potential medications that are used inappropriately, and then evaluate medications that we could possibly incorporate into the prescribing algorithm. So first, we'll go through what de-prescribing is, discuss polypharmacy in both Ontario and BC using our databases and some future directions we are going. So the reason why we're going to talk about polypharmacy is that we started first with the idea of de-prescribing, which is the process of tapering, stopping, discontinuing, or withdrawing drugs with the goal of managing polypharmacy and improving outcomes. So why would we be prescribing hemodialysis? Well, I think we all know that they have a high pill burden. The evidence for efficacy of many of these therapies is lacking in this population, and of course there are safety concerns as we're worried about some medications being cleared by the kidney that's not functioning or not removed by hemodialysis. And currently, there are no tools for de-prescribing available in this population. So let me ask the audience, what medication would you de-prescribe in hemodialysis? I should add one more. ACE inhibitors, proton pump inhibitors, insulin, antidepressants, I should add all of the above, but we'll leave that out for now. So ACE inhibitors, proton pump inhibitors, yes. Insulin, okay, good. Antidepressants, okay, I think so. Which really brings me to the term of polypharmacy, and another term, potentially inappropriate medication. So polypharmacy means many drugs, and the literature defines it as 5 or more drugs per day. Polypharmacy also means inappropriate choices of medication, which is really potential inappropriate medication, which is defined as medications whose adverse drug events exceed their expected clinical benefit. So we know there's many consequences of polypharmacy on people. There's decreased adherence to medications, drug-drug interactions, there's adverse drug reactions. And 68% report an adverse event after hospital discharge, and 72% of it is due to medication. We know there's consequences on the healthcare utilization, there's more hospital admissions that could be preventable, that are drug-related. On cost, unfortunately, we spent more than $4 billion to spend some public drug programs of drugs for the elderly, Canadian data, and 20% of this on healthcare spending. The risk factors for polypharmacy include age, many comorbidities, acute hospitalization, healthcare visits, and multiple providers. Of course, we all know these are risk factors of our typical style patient. So what about polypharmacy in cases? So if we go back to 1998, that's a long time ago, some of you were probably still in high school or elementary school. Not me. I was graduating from pharmacy, but the U.S. Renal data system printed or reported that dialysis patients were on a median of 9 medications per day. They later redid the study, 6 years later, 2004, and there were 12 medications. There were 12 medications per day. And we know from some of this literature that a high number of prescribed medications for dialysis patients is associated with decrease in their quality of life, decrease in their adherence to treatment, and increase in mortality. So this brought us to, well, what do we know in Ontario? And so first, let me ask you one more question. What is the most common medication you think is prescribed to dialysis? Proton pump inhibitors, benzodiazepines, statins, or opioids? A. Proton pump inhibitors, raise your hand. Prescribed. I know it's quite close one. Benzos? Okay. Statins? Okay. Opioids. Okay, so I'll show you some data. Statins in Ontario. Okay, what's the most expensive medication used by dialysis patients? Proton pump inhibitors. Okay, insulin. Statins. Opioids. Okay, we're getting no. Proton pump inhibitors, most expensive drug. Okay, insulin. You said statins. Okay, opioids. It's hard to know, right? They're all commonly used and they're all expensive. insulin. I'm going to show you some Ontario data. Yeah, I was shocked by that one. I think probably because I didn't think about how much insulin the patients really need. They need it. Okay, so the reason why we looked at the study is a group of us are involved in the de-prescribing. It's a national study that we want to implement across Canada. And we had done a small study at our Fine Center published last year looking at, we developed 5 algorithms, implemented it by doing a medication history, finding the patients on the medication, last 15 to 10 times stop these medications, and follow them. And so it was successful, and we were able to stop medications in these patients. So when we brought this to go forward nationally, we thought, well, we really need to know for sure. We picked those 5 medications in my dialysis and just put them in a chart in the community nephrologist, but we really needed to understand what is the use of medications in Ontario. Which medications do cost a lot, potentially are used, and we really don't know the data behind it. And so that's what sort of generated this study. And so we have data from Ontario and BC and some looser data from Alberta. They were kind enough to share some of their database information. So today we'll present Ontario and BC data. So this is a descriptive, retrospective cross-sectional study in Ontario. We used 7 administrative databases. This is all stored at the Institute of Clinical Evaluating Sciences. And so we assessed outpatient medication with prevalent hemodialysis patients in 69 facilities in Ontario as of October 1st, 2013. That was the ability to go back and get full data. And active prescription drug use is defined as evidence of at least 1 medication dispensed in our Ontario drug benefit in the prior 120 days. So in Ontario, if you're over 65, you fall under the Ontario drug benefit program. If you are disability and social workers, so in other words, welfare. Recently, we've also in January implemented less than 25 years old as well. So for us that have kids and don't have drug coverage, we have great coverage, but we would have our kids being able to be their drug coverage would be under our Ontario drug benefit. But this data did not include those patients because it goes back to 2013. So at the time of the study, there were 5,700 patients on dialysis. We excluded anyone who didn't they didn't have a prescription for any of these drugs 120 days prior to this October 1st date, and we excluded anyone who was changing modalities within 3 months, 120 days before that. So you can see over 2,000 patients do not have the drug prescription and the ODC. So that would be private insurance people who pay cash or out of pocket for their medication. So we ended up with just over 3,000 hemodialysis patients that were able to do that. So this table 1, baseline characteristics of patients on dialysis. So let me point out a few things. The typical age or median age was 76 years of age, so that's no surprise with our ODD really focusing on people over the age of 65. Interesting, the median dialysis was just over 4 years. So if people have been on dialysis, for me, a pretty long time. Typical comorbidities that you would see: coronary artery disease, diabetes, heart failure. No surprise, this is what our typical dialysis. What about medication and healthcare use of these patients using a study medication? So, interesting, the median number of medications was 11. But remember, ODB doesn't cover OTC medication. So, it doesn't account for calcium carbonate, which is our main phosphate binder. Reclamite is not covered by the ODB, as well as things like Venifer and Aranesp. They're covered under a different ministry, different act to medication. So, this likely number is a little larger, like closer to 14 or 15 medications. Primary care visits. Interesting. The median number of primary care visits, so not dialysis visits, but primary 7 in a year. Okay, so I thought that was wow. And the number of different prescriber specialties, median number was 3. There were 3 different types of prescribers. And their specialty, most of the prescriptions came either from a general practitioner or a nephrologist. Again, what about the percentage of medications used? So this was looking at all the medications, so all comers. Like we didn't specify which medications, so anything that they were prescribed and they had failed to the ODB. So here's your number 1 drug, statin, followed by PPI, diuretics, opioids, which no surprise, benzodiazepines, warfarin, allopurinol is right up there too, antidepressants, and then it starts to get smaller numbers. We did this because we were interested in which one of these do we really think that we should actually think about de-prescribing. Some of these medications really don't have great evidence for them. When we looked at costs, we looked at costs across the whole board. Just to go back, this one doesn't account for things like ACE inhibitors, ARBs, beta blockers. Yes, they can be inappropriately prescribed, but we weren't looking for those types of medications. We were really looking for ones that really didn't have as much evidence for use. Okay. When we looked at costs, we looked at all the medications across COPD, and so insulin was the most costly medication, followed by PPI, probably because the number of people on it. Calcitriol was far behind there. That one surprised me. Statins, and then your typical medications that you would use, channel blockers, beta blockers, ACE inhibitors. Okay, so I'll let Judith finish with some things to compare data and
So we did actually quite similar review for how we were prescribing medication. So we took a BC Pharmacist database, which contains all the information in terms of demographic data, lab data, and medication profiles for dialysis patients. And we excluded all patients that were changing modality within, so they had to stay in the same modality for at least 120 days during the study period. We actually decided to have the same study period as Marisa, just to make sure that it was, actually, no, that's not true. We took 2 study periods. We looked at Marisa's study period, but we looked also at a more recent study period to be able to match the Manitoba database. And but both data were actually really similar. So I'm going to present the 2015 data, but actually both were really similar. The only thing that was excluded from the analysis were all the herbal supplements. And so our age is a little bit actually, the mean age is actually a little bit younger than what is seen in Ontario. And the way that I divided the data was HD data, PD data, but also overall dialysis patients. And so our age group, the mean age was about 66 years old. And you can see that most of the patients were between the age group of 65 to 80 years old, with about 20% of the patients being an elderly patient, older than 80 years old. Diabetes patients, it was about 70% of the patients that were diabetic as a comorbidity that were entered into the Pharmacist database. And the median dialysis vintage years was 3.3 years, with most of the patients that were on dialysis for more than 3 years, but take into consideration that most of the patients were hemodialysis patients. Most of the patients on PD had been on dialysis between 1 to 3 years. So, and actually I left this line, you see it, the first line, because that was telling us like 99% of the patients had actually one medication entered into the database. So that was confirming that the data that we had there were probably actually reliable data. And there is a big initiative in BC about doing medication reconciliation every 6 months for all dialysis patients. So we were quite happy about the reliability of the data that was in there. So for our patients, the median amount of medication that were taken was 17.7 medications patients were taking. The amount of PRN was 5.3, so still they were taking 12 medications regularly on their medication profile. And we decided also to divide like where were the medications, for which condition were the medications for, like was it the cardiology medication, how many patients were on medication for cardiology, diabetes, renal, symptoms management. So you see that a lot of the patients are at least on a cutout for this. and the number of medications per different indication. So, an average patient around 3.5 medications for cardiology, 0.6, but that, I mean, depending if you're diabetic or not, so probably shouldn't look at it too much. But renal medication was 4.7 renal meds. For symptom management, it was 6, and other medications, about 3 medications. And so if the patient was diabetic, they were on average on 18.5 medications versus non-diabetic patients that were on 15.9 medications. And if you look at the age group, as patients were aging, they were on more medication. But between the patients that were between 65 to 80 years old and the 80 years old plus group, there was not a huge difference in the amount of medication that they were taking. So 18.4 for the patients between 65 to 80 years old and 80 plus were taking an average of 17.3 medications. And by dialysis vintage, medication was also increasing the longer they were on that. And interest, well, probably we know, but PAD patients were on less medication in average than and looking also at, so Marisa touched base a little bit on the potentially inappropriate medication. So we've looked at the same list as Marisa and said, okay, if we're saying that these medications are potentially inappropriately prescribed, like how many of these, like what is the scope into this type of medication? So we found that about 97% of the patients were at least on one medication that was potentially inappropriately prescribed. A lot of them had to do with cardiology, but a lot of them also were symptom management, like 90%. And I think that we're really good about prescribing stuff, but to reassess them might be something that we need to look at a little bit more. And the older patients were also on a lot of potentially inappropriate medication. The average was about 5 for patients that were older than 80 years old. And with the dialysis vintage also, there was more inappropriate medication being potentially prescribed. So take-home message is that polypharmacy is a major concern, that we need initiatives to try to improve prescribing and to make sure also that the patient understands like what is actually very important and what are more the plus than what is maybe not something that is really needed, and for us also to be really good about cleaning up their medication list. And coming in that is a big difference in prescribing national study, which actually Joanne is taking part to. Marisa is leading the project. Callie at the back is also giving some input on in terms of looking at how can we, what is appropriate prescribing in these patients and which type of circumstance we can actually discontinue medication. What are patients' preference also in regards to that? And to take it from there to see also that the financial resource also well spent in our healthcare. Any questions?